Tizian Rosenstock, and they're going to talk to us a little bit about their recent paper and a subject that I'm super interested in, which is using transcranial magnetic stimulation really in the post-operative period, and some fascinating results. So Dr. Krieg, Dr. Rosenstock, if you guys want to introduce yourselves and then get us started. As always, I'm here with Jason Sheehan and Chris Cifarelli, who need no introduction because they're esteemed partners and colleagues. But
thank you very much for the invitation. My name is Sandro. I'm the head of the neurosurgery department here in Heidelberg University Hospital, and most of the studies or the data comes still from my part as vice chairman at the TU in Munich. And since a lot of years now, I think with Berlin almost more than a decade, with London almost a decade, we're really close collaborators with the other partners.
Yeah, hello, my name is Tizian Rosenstock. I'm consultant in the Department of Neurosurgery in Berlin, Germany. And I really appreciate it to do the multi-center study and analysis with my colleagues and friends, Professor Krieg and also Professor Vergani, who's also here in this meeting. And it was a pleasure, and yeah, really looking forward for your questions.
Dr. Vergani, you were off the screen there. I didn't get a chance to see you. Sorry about that.
Hello, I'm here. I'm Francesco Vergani, consultant neurosurgeon from King's College, London. And it's been a pleasure and really an honor to be invited in this session. And it's been a privilege for us to participate into this study.
Amazing. So Dr. Krieg, Dr. Vergani, Dr. Rosenstock, if one of you want to kick it off, I don't know if you have any slides you want to show. Just give us a summary of what you've been working on.
Yeah, so this is basically the paper. Here is the publication Journal of Neuro-Oncology. So, I mean, we all do quite elaborate workup now before we're doing surgery. This is how we do it when we started doing TMS. We do also function-based tractography in yellow here for corticospinal tract, and in purple, you see more or less language tracts. So, and this is what we do for highly eloquent tumors. But some of you know, and sometimes when you or patients of both have bad luck, what do we do with all that elaborate workup fails, and you end up with having a ischemia and a patient waking up with a severe paresis after surgery? So if you look at the literature in stroke, there is a bunch of articles and studies on TMS, and most of them use, as you might see here, quite similar protocols. Some were positive, some were actually negative. There were, when we started, 14 randomized studies. And we can get to the discussion why this is so heterogeneous. So we thought, well, this is a principle we might aim for. And the principle is called transcallosal disinhibition. So we know that the bilateral motor cortices inhibit each other through the corpus callosum. And if you have, like here on the right side, a healthy motor cortex and an injured one on the left, you still have an inhibition through the corpus callosum. So the healthy motor cortex makes the injured one even worse. So the basic principle is, let's just reduce this inhibition and create a disinhibition. So what we did in the study, we inhibited the healthy motor cortex as in the stroke trials. This is about 15 minutes of repetitive TMS, so 1 hertz repetitive stimulation, roughly 15 minutes. Then after that, 30 minutes physiotherapy, and we did this for roughly 7 days post-op, starting depending as soon as possible after surgery. Usually we aim for post-op day 1. And there were 2 studies from Munich and then Berlin as well, where the basic hypothesis was that post-operative TMS therapy improved 3 months outcome in post-surgical ischemia-related paresis. And for the sake of time, I present roughly the first results of this randomized double-blinded and sham-controlled study, which one was done in Munich and the other one in Berlin. And we used the Vogel-Meyer assessment for like small motor movement in the hand as a very accurate measurement of motor function. And what you can see here is that you have in follow-up 3 months after surgery, a significant improvement of the patients in the Vogel-Meyer assessment. And as literature says, if you take minimal clinically important difference of 10 points, you end up with a number needed to treat of a bit above 2. So we and all our collaborators also did this therapy besides the randomized studies, which is King's College in London, Charité in Berlin, and also MD Anderson in Houston. And altogether, we came then up with 135 patients, including those 2 RCTs and including it's actually 4 one-arm studies because all centers also had a follow-up study. And we included brain tumor patients with surgery-related post-op paresis, so more or less severe paresis, at least 3 out of 5 or worse. And these are the results we saw of those patients. So you see here BMRC grade, post-op day 1, 7, and 3 months. On the left side, on the right side, the Vogel-Meyer, in those where it has been done. You see the sham also improves a bit in purple, but not as much as the therapy group. And the same roughly, not that much, but it also is, you see it in the KPS and in the NIHSS. When you look a bit closer in the NIHSS and you look at the 3 months, so post-op versus 3 months, you see here in this plot that we have a tendency, not a tendency, but significant results for treatment has a better effect than sham. And the same is if you take out only those patients with ischemia on post-op MRI. Since it was a big cohort, not only those patients with an ischemia were enrolled, but also others. But if you only take those with a subcortical ischemia in post-op MRI, you have even stronger treatment effects. And for KPS, we have, it doesn't even matter in which group, even after 7 days of therapy, you have a strong treatment effect. So we see an advantage in the treatment group in this large, it's still something rare, luckily. So we still have a large series of those rare events. If you take BMRC, you have an odds ratio of 4 to 10, depending where you see your outcome. The number needed to treat is depending on what you take. So if you take BMRC, it's 4. If you take KPS, it's 3. And if you only take the ischemic group out, you even end up with your number needed to treat of 2. So we conclude that for us, we have another tool now for surgical neuro-oncology. So if you do everything for your patient, but you still end up with a patient having a severe paresis, you still now have a tool where you can actually do something against it and create a better outcome after surgery, even in days after surgery. And coming from that, the modulation of functional reorganization, so the kind of prehabilitation of the motor system seems also to be the next step after this study. And for us, NTMS, so navigated transcranial magnetic stimulation, not only nowadays is a preoperative modality where we do pre-op mapping and get an idea of the functional anatomy, but it's becoming more or less a perioperative modality which we can use pre and post-op if we need to. So with that, I'm again thanking you for the invitation, and we're really curious about all your questions. Thank you.
Thank you. Great summary. I'm going to open it up, obviously, to the viewers at home and the panel for any discussion points. I find this so curious. So you guys are using a portable machine, or you're bringing the patients to a bed's, the fit chair that you need for the TMS machine?
You can do it in a bed as well. Doesn't matter.
Yeah. And then, sorry, I'm going to hoard all the questions for a second. These, did you guys collect whether patients had intraoperative monitoring changes, or, how do you quantify, someone wakes up weak, was it a change in motor evoked potentials, or was it just based on physical exam?
Tizian, do you also want to answer? Or
Yes.
I can do as well, but you can as well.
Of course. So the inclusion criteria was depending on the postoperative motor status, so the clinical status. And some centers also assessed the postoperative neurophysiology. So if the MEP were still present or not, but that differs between the centers. So
Yeah.
the clinical status was the most important thing in the inclusion criteria.
Okay. Yeah,
So,
I think
with TMS, you can also check for your MEPs postdoc, right?
exactly.
And in the RCT, we investigated as well, what about the group who doesn't have any MEPs left? The percentage of patients who recover is less, but you still have patients who recover.
That's fascinating to me. I mean, and the reason I asked, just, it doesn't detract from the findings. Even if this is an SMA syndrome, where your motor evoked potentials would be maintained, but someone would wake up weak, you're seeing a pretty rapid recovery of function with TMS. So if the motor evoked potentials are gone and you're seeing recovery, great. I can't wait for that paper. But if they're present and you're seeing a rapid return of function, that's similarly very important, especially in those SMA cases. And so, I find it super, super fascinating how you guys are doing this. Any other questions from Jason or Chris? So it's not just me.
Actually, one question I had for you, and I think your last slide kind of led into this, was what's the role for this therapy in sort of prehabilitation? So we think about this in spine and trying to optimize patient outcomes. And, a lot of what we do is fairly urgent when it comes to patients who present with large tumors, but some of your patients had lower grade tumors that might afford the possibility of maybe a week or 2 weeks to be able to intervene beforehand. And do you see a role in trying to optimize the patient's potential outcome when you think maybe in fact they're going to end up with some form of deficit from the surgery, even regardless of perfection of technique?
Please.
I think it's a great idea, and it's also something which we are trying or figuring out now. So to do repetitive inhibitory stimulation near the functional areas, near the tumor, with the aim to shift the function away from the tumor. And we need to investigate how far we are successful then.
Yeah, how many treatments do you think you would need to elicit an effect? Like, do you think it would need to be, a week's worth of treatment, just a couple? What's your general kind of gut feeling on this?
So in our protocol, we are stimulating at least 5 days, up to 10 days. But as you said, it really depends also on the imaging, right? What you suspect, which you have a high-grade glioma or low-grade glioma. Of course, you have more time in the low-grade.
Yeah, of course. Thanks.
We did it for a language case as well. There we did 3 weeks. But I think the strength of our post-op therapy and the comparison to the stroke trials is that it's a small lesion in neurosurgery usually. It's not a big stroke where you don't have any chance for recruitment of additional tracts. And the other part is we start very early. So it's post-op day 1 or 2 usually. So we don't get into any chronic phase. And for the pre-op, our current protocol says 5 days. We'll see. From the tendency, we should do longer, but it gets unrealistic, right?
Sure. They need the tumor out.
Well, what do you think? I mean, with language also, you're talking about and I'm not saying motor is not a complex network, but language is a very complex network. And so targeting, I imagine, is tricky. And whether you're doing stimulation or inhibition, here you've got a pretty, sweet setup of the contralateral side, with the planned treatment effect. How do you guys view that you would expand this to other networks?
Well, I mean, maybe every one of us 3 can answer one try they did. I mean, what we do is, if you have, for instance, so the first case we did was a low-grade glioma in the triangular part of the IFG. And in the opercular part, there was also a bit of a tumor load, and I wanted to resect it. But there was still language in awake surgery, so we knew there's language. So what we did is we inhibited this opercular part, and the patient in the evening was speaking verse. So he got inhibited like for 15 minutes a day. Next day he recovered. We increased the stimulation intensity, inhibited again, and this is what we did for 3 weeks. And after that, at least what we measured, we didn't see any cortical function there at all for language, at least for overt language.
That's in a prehab setting, though, right? You're talking about the prehabilitation. What about postoperatively? I mean, you said you did try in some language patients postoperatively?
We only did pre-op for language, but maybe the other two can answer. Maybe Francesco?
So if I may just add something on this topic, which is just a sort of a general remark, why I think that TMS has a role in brain tumors. And this is both pre-op and post-op. And the main difference that I see with stroke is that while stroke is by definition, hyperacute event, when there is no plasticity happening in the brain when the stroke happened. With a tumor, even with a high-grade glioma, usually takes weeks or months to develop. And so you can argue that there are already mechanisms of plasticity that are happening. And what I think that we do with the TMS is that we tap into this plasticity. For language, I agree, it's more difficult. And I think that we have still to understand whether it is better to inhibit some areas or try and stimulate other areas that may also play a role in language. But for motor, I think that we already are seeing very encouraging results.
So in Berlin, we have a small feasibility case series to treat postoperative language deficits. And what we figured out is to do excitatory stimulation near the functional areas, near peritumorally, to try to enhance the function there. And on the other side, we do contralateral inhibitory stimulation, analogous to the motor stimulation trial, to decrease the transcallosal inhibition. So bilateral stimulation.
So, let me ask you, and just for, we have a combination of people viewing. We have neurosurgeons, we have students, we have just lay people who also follow along. I think I understand what the hypothesis is here, but how do you hypothesize that recovery is happening? Because in my, rudimentary way of understanding this, there's a cortical center that says to make a movement, and then there's a telephone wire that brings that information to where it needs to go to make the movement. If you cut the telephone wire, how is the signal getting through? How is TMS augmenting that signal to get through?
I mean, the basic theory is that the interneurons in your injured hemisphere, let's say, they inhibit some of your pyramidal cells as well. So you take off this inhibition. This is at least my theory. Maybe the other two might add something.
Francesco, yeah, Tizian.
Yeah, and another theory, I suppose that these are cases where you don't have a complete transaction of corticospinal tract, or at least of the corticomotor neuron component of the corticospinal tract. Because otherwise, I think it would be difficult to imagine regaining movement. But it's probably to recruit. The fibers are there, but it's probably to recruit more cortical centers that project through those fibers that are still present.
Yeah, I think I don't have really something to add. I think it's not black and white, right? So if one would resect the complete motor cortex or the whole cortical spinal tract, and I think we can do as much TMS as we want, and no function will be regained. But however, it's kind of a partial injury to the motor system. I think that's the point where we can tackle with TMS most efficiently.
And this again, if I may add again one little remark, and it's what Sandro already alluded to, that in our cases, even when a subcortical ischemia was present, these were very focal and small volume infarct. And this again is a difference compared to the stroke trials, where sometimes, the stroke volume was very large at both cortical and subcortical level. Luckily with our surgical refinement of surgical skills and technique of intraoperative neuromonitoring, we can probably avoid causing very large ischemias.
Definitely.
Yeah, I'd like to
Go ahead, Jason. We have a question from the audience afterwards.
Perfect. Look, this is I read this article, sent out for review. I thought it was fantastic. Once accepted after it had gone through the peer review process and revisions, I even put this on my own social media channels because I thought it was just so important. I thought it was so novel. I wanted to tease apart a little bit from a neurosurgical standpoint. Two questions really around potentially the value proposition of this for low-grade glioma patients. I know that was a little bit of perhaps a study accrual issue, or maybe it was by design. And I wanted to ask a little bit about that, as well as recurrent tumors. What do you think the value proposition is for TMS in those patient populations that were perhaps not as well studied in this particular project, but undoubtedly you probably have insights and perspectives that you might be able to offer in those patient populations. In other words, do you think that the low-grade glioma patients and or recurrent tumor patients, high-grade or low-grade tumor patients, really have likely the same degree of response, better or worse response for TMS than what you might have shown here in this study, which I think is outstanding?
Thank you so much. I mean, by clinical experience, it doesn't make a difference actually. And I even remember a case of a aneurysm coiling and a young woman who had an ischemia really only in the hand knob. Young 30-something lady. And we did this as well. And she recovered, I mean, she might have recovered as well, but she recovered really within 7 days completely. Even, I mean, I have, unfortunately, some weeks ago, an old lady with a meningioma, and she developed some swelling, and then, swelling, and the veins get closed after surgery. So, and we did contralateral stimulation as well. And it was like, my team was like, oh, this lady recovered kind of quickly. So I think it doesn't matter which pathology, it matters what happened afterwards. But maybe
we also analyzed this in our study, right? So we did some subgroup analysis for primary tumors versus recurrence, and gliomas versus other entities like metastasis, and we could find for all the subgroups the treatment effect. So it's also according to our real life, right? So we could not choose every patient. If we have a patient with a recurrence and a post-operative deficit, we want to treat him or her. So we were very lucky that also the subgroup analyses were fine and supported our results.
So from the ischemic standpoint, you guys don't think there's difference between an arterial infarct versus a venous infarct in this setting that's iatrogenic from the surgical resection?
It seems we don't have that many patients with venous infarction. This is one I just remember, but
sure.
I think I do share your concern, and I've also always thought that venous infarct are even less forgiving than arterial infarct. And I think, I think it would be very interesting to apply this methodic of TMS rehab, even in patients with venous infarct. Certainly, I don't think that would be an exclusion for me. Whether we are going to see very good results, I don't know, but it's certainly worth exploring this.
And I think that's a great question, Chris, and great response. One other question I had, which was really around the timing of adjuvant therapy for these patients and what implications, if any, you think it may have for timing of TMS. Do you alter adjuvant therapy timing? And I noticed in the a reference just this for the sake of the audience, but in table 1, there really were some differences in terms of the technique for TMS. But is there any change that you would do if someone were going to get early adjuvant therapy versus maybe delaying the adjuvant therapy for the sake of TMS and the potential benefits that may occur?
I mean, I would say no as a quick answer, and as a longer answer. When we did the first study, we said, let's make it 7 days, because the stroke trials were all like 3 weeks or something. We said, that's unrealistic. Let's make a study and put everything in, try 7 days. 7 days inpatient is already long. Even do therapy on the weekend. I remember myself doing it on Christmas morning, because you needed to blind the investigators. So you always needed to have 2 people. I think, no, since 7 days works, it doesn't prolong anything.
But delaying adjuvant therapy onset is not necessarily something that would, in your mind, necessarily benefit the response that you're seeing for TMS. It doesn't sound like it, and it doesn't sound like that was ever a consideration. I agree that the 7-day approach, which was done in all centers, really is a very practical one. There's no, I can't, other than having to come on Christmas Day, which I commend you for, 7 days is something that's very manageable, either in an inpatient setting or an outpatient setting, or a combination of the two.
Maybe the other 2 can add something. I didn't think about it, but since we see between 7 days and 3 months a really good improvement,
right,
of course, there's a rationale to wait, but maybe the other 2 can add.
No, I agree. I think that 7 days seems a very reasonable time frame. And also considering that we start this therapy with repetitive TMS really early, usually 24, 48 hours after surgery. And so the week the patient spends having their rehabilitative TMS is not really going to delay any adjuvant therapy. On the contrary, what we have seen is that some patients improve to the point where they are in a much better position to undergo chemoradiotherapy, even in high-grade glioma. Patients that maybe would have really struggled to have radiotherapy due to their hemiparesis improve to the point where they were, and the oncologists were more confident in treating them.
Yeah, to be clear, I wasn't thinking that you had to delay it. I'm just wondering, with this plasticity that may be occurring, whether or not a little bit more of a delay, particularly around the radiation, could potentially be a benefit. But I think we would need more data. It's incredible what you found. The number needed to treat, just an incredible response. I mean, I guess I would say, why wouldn't you do this if you could? I mean, obviously, if you had the appropriate patients and the technology to do so, I think it is something that you nicely demonstrated has a very low number of patients needed to treat to benefit. So wonderful. I think we have some questions from the audience, Randy.
Yeah, we're running a little bit low on time, so I think this plays into nicely, though, the discussion we were just having. The question from one of our viewers is, how vital is the timing of postoperative TMS? And is there a role or benefit in your mind in a delayed fashion?
I think we'd always try to be very early, but we didn't see a difference as far as I remember between patients who started at day 1 or 2. Right, Tizian?
Yeah.
Yeah.
Well, there's no reason to wait for 2 or 3 days. The patient recovery should start tackling the motor rehabilitation as fast as possible, as my colleagues already stated.
Yeah. I've heard reports, at least anecdotally, of people getting treated, periods of time later, 3, 6 months, 1 year, with improvement as well. And when you look at the TBI data for fMRI and the recovery process, there are kind of short changes in the recovery from TBI, and then there are kind of long-term changes, and with regards to other networks facilitating communication and whatnot. And so I think that this upfront therapy makes the most sense, though. Like you said, it's before any sort of chronic period gets solidified, and you're addressing things early, and the dysfunction that's arising early. So I think it's fantastic.
Really appreciate you coming on Tumor Talk and obviously publishing in the Journal of Neuro-Oncology. Hope there's more work to come from the group, and the really truly impressive research. Thank you so much, Randy.
Yeah, it's been a pleasure. Chris, any final words from you?
No, thank you all. This is great work, and I can't wait to move our TMS machine from our outpatient center to our inpatient side so we can start doing the same.
Can I borrow it?
Sure.
Anyway, guys, great. Thanks so much for joining to the audience, and we'll see you in 2 weeks. Take care, everyone.